Welcome to this presentation on neonatal pharmacokinetics. It's based on the simple premise that I learned when I was studying for my MSc, the fact that drugs don't have doses, patients do. When you were at university, no doubt you studied pharmaceutical care, which is the concept of identifying and meeting the drug-related needs of individual patients. And I would suggest to you that neonatal clinical pharmacokinetics meets both those aims. So this is a new presentation which I'm trying to develop based on blended learning. So the blended learning concept is you get a short video, some background reading, training packs, etc. that you can watch and read as often as you like, give you some exercises, and then at some point in the future we can work in groups or individually to work through some of your practice examples of applied pharmacokinetics. So pre-reading, I'd advise you go back to your undergraduate teaching, look at your clinical pharmacokinetic sessions, pick up a clinical pharmacokinetic textbook, get access to the neonatal pharmacokinetic training packs and assessments, which cover both gentamicin and vancomycin. And most important, get yourself a scientific calculator and identify how you use it and any quick shortcuts. You're going to be using this tool to do exponential multiplication and some logarithmic assessments. So make sure you've got access to that and you actually know what the various functions do and how you can save things within the memory space, etc. Initial questions, we'll be talking about half-life. So what does half-life actually mean? What does a half-life tell you about dosing? In my simple mind, if you're aiming for a peak of 8 and a trough of less than 1, in one half-life your peak will fall from 8 down to 4. In one half-life it will fall from 4 down to 2, another half-life 2 down to 1, and another half-life 1 down to 0.5. So basically with aminoglycosides you may be dosing every 4 or 5 half-lives, whereas with vancomycin that may have a slightly longer half-life, you're aiming for the peak to be about 20 and the pre-dose trough to be 10. Therefore, you would be giving doses every half-life. Volume of distribution, what does that mean? Well, in the kinetic workup, we will look at the concentration rise that a dose gives and then correlate that with the corresponding volume of distribution. But it's important to recognise that the concentration rise you get depends on the dose that is actually delivered. And if you give incomplete dose, then you're going to get a small concentration, and a small concentration rise does not necessarily mean a large volume of distribution, because clearly if you've given a smaller dose or not all of the dose has reached a patient, that will be reflected in the concentrations that you measure. And then we will work out elimination rate constant and have some thinking about what elimination or K value actually means, because you can use that to extrapolate to what concentrations will be in the future, but you can also use that to back extrapolate to find out what concentrations were in the past. So, neonatal sepsis. We use benzylpenicillin and gentamicin first line for early onset neonatal sepsis and late onset neonatal sepsis, so sepsis after 3 days of life. We would use comoxiclav and gentamicin. So you can see all of the regimes that we use initially involve gentamicin, therefore it's useful to have an understanding of the kinetic process. Aminoglycosides demonstrate concentration-dependent killing. So generally we aim for a peak of between 8 and 12 and a trough of less than 1, but ideally less than 0.5. As the peak increases, so does the post-antibiotic effect, and therefore so does the duration of the concentration-dependent stunning of bugs. So concentration-dependent killing, we all recognise that. And one of the challenges in neonatology is, well, in adults we just dose based on renal function, but with a premature neonate, it's very, very difficult to get an assessment of renal function. So initially the serum creatinine is a reflection of maternal creatinine, therefore doesn't actually tell you what the baby's kidney function is like. And then as it gets older, then it's more a reflection of hydrational status. So we can't actually do any sums to work out this is the creatinine clearance. Important to recognise that antibiotics in neonates is a time-critical intervention, in that if you miss the opportunity to treat a baby with group B strep sepsis, if you delay antibiotics by a number of hours, no matter how many or how much antibiotic you throw at the baby, you will never be in a position of survival, because bugs will overwhelm the baby that doesn't have a functioning immune system, and it will die within a number of hours. Important to recognise that with dosing we run the risk of giving too small a dose, and also the risk of drug accumulating and causing possible side effects and harm. So NICE came up with dosing recommendations. They suggested 5 milligrams per kilogram every 36 hours was appropriate for early onset neonatal sepsis. The second dose is to be given measured of trough blood concentration immediately before giving the dose. And then if treatment is continuing, you're actually thinking about amending dosing possibly 3 days after you've started it. This advice is followed on the postnatal wards. The reason we follow it on those areas are because these are bigger babies. We tend to be more confident about the concentration rise that we will effect with this 5 milligrams per kilogram dose, and their renal function is generally more predictable and more reliable than it is in the 25 weeker 700 gram baby down in neonatal intensive care. So we did an audit to find out, is NICE guidelines or BNF dosing appropriate in our neonatal population? So Sean Morgan kindly did this as one of his postgraduate diploma projects. So we looked at babies that were receiving gentamicin, and if they were 7 to 28 days old, we would expect them to be on 5 mg per kg every 24 hours. If they were less than 7 days old, then we'd be expecting them to be on 5 mg per kg every 36 hours. And our target was a 1 hour post-dose peak of 8 to 12 and a pre-dose trough of less than 1 milligram per litre. What we found was 20% had a NICE dose, as in it corresponded with NICE or BNF for children, and 80% didn't. So here we have a case of, if we follow national guidance, then there's a 1 in 5 chance that we'll actually be giving an appropriate and effective dose. If you think about it, drugs don't have doses, patients do, and the basis of pharmaceutical care is to identify and meet the drug-related needs of individual patients. Then it doesn't actually follow true that we will actually be achieving that with standard dosing. So this is a page from the neonatal kinetic training pack. So you've got how to work out an elimination rate constant based on 2-timed concentrations. You've got how to translate that into half-life, how to work out an individualized volume of distribution, and then how to apply these to work out a dose and dosing frequency to achieve an appropriate target concentration. So this is the basis of all the application that we do in clinical practice. So I'd recommend you spend some time to actually contemplate, consider, and understand this important concept. So moving on to examples. Theo was 26 or 27-week gestational age baby born at 555 grams, 0.55 kilograms, and he received a stat dose of 3 milligrams of gentamicin at 16:12 on the 25th. Concentration on the same day at 1800 hours was 8.1. His concentration, second concentration, the following day was 2.4. So what we do in an example like this is calculate the elimination rate constant, half-life and volume of distribution, and then use the applied model to work out a peak and trough, a suitable peak and trough concentration. So consult is documented thus. We've got a dose of 3 milligrams given at 16:12. First concentration was 8.1, and this was taken 1 hour 48 minutes after the peak concentration. The second concentration, or after the dose was administered, and the second concentration is 2.4, which was taken 19 hours and 24 minutes later. So we can calculate the elimination rate constant by taking the natural log of 8.1, subtracting the natural log of 2.4, and then dividing by 19.4, which is 19 hours and 24 minutes expressed in decimals. You get an elimination rate constant of about 6%. That translates into a half-life of 11 hours. Their volume was calculated to be 0.33 litres, and their estimate was 0.26 litres. So with these figures, you can then work out a suitable dose and dosing frequency. Important to recognise that the sample times reported on Cerner within labs is not necessarily the time that the sample was taken. So you can review this by going into the history of the order, or if blood gases were taken in quite close proximity. So say you had a blood gas taken at 17:45. The chances are they took that blood, took it to the machine and then analysed the gases, because they've got to do that immediately, and then generated a label a few minutes later and sent that off for a gentamicin concentration. But the sample would be taken, we wouldn't take a sample 15 minutes after taking an arterial stab to take a blood sample for a gentamicin concentration. So a recommendation is advise a maintenance dose of 3.5 by slow IV bolus over 3 to 5 minutes every 2 days, every 48 hours, to achieve a pre-dose trough of less than 2 and a post-dose peak of 8 to 12. Put in a note to say we've not rounded the dose to the nearest milligram in view of the very small dose volume required. Next dose was due at 11 o'clock in the morning on 27th. And we recognise that gentamicin tends to be given at 11 and 11 on the neonatal intensive care unit, simply because that's shortly after ward round is complete. Nurses had some experience of caring for the child, and 11 o'clock at night, you've got a shift changeover at 7 o'clock. Therefore, again, nurse would be in control of the situation, and they're more appropriate times to give doses. So if you calculate the next dose is due at 8 o'clock at night because it's 48-hourly dosing, and they got the dose 48 hours earlier at 8 o'clock the night, round it to the nearest sensible time, and you can calculate what the concentration would be at any time using your elimination rate constant. So then documented pharmacist has prescribed it. We've put in a note to say how long the consult took. So second case is transfer from second case is a slightly more mature baby, so gestational age 37 weeks with a birth weight of 3.65 kilograms. They received 19 milligrams at 5 o'clock in the morning. Their First concentration was 8.3, their second concentration was 3.2. And again, with this detail, you should be able to work out elimination rate constant, half-life, volume of distribution, and work out what an appropriate dose and dosing frequency would be. And important to recognise that you can do this in your head, in that, in my simple mind, a dose of 19 milligrams looks like it's a reasonable choice because it's given a concentration rise of 2.5 hours post-dose of 8.3, therefore seems reasonable. But you've got a much more rapid clearance because in a 5-hour period, it's gone from 8.3 down to 3.2. Therefore, you're looking at half-lives of 5 hours as opposed to 11 hours. So this baby previously received a dose of 18.15 milligrams of gentamicin at Leighton Hospital. Interestingly, 18.15 is 1.815, so that physically cannot be measured. And one of the benefits of working at Wirral is we round doses to sensible, measurable volumes. So we had a stat dose, we then gave a second dose of 19 milligrams, and we've got concentration of 8.3, 2 hours, 12 minutes post. Concentration 2 was 3.2, which was 5 hours, 49 minutes post. And when you do the sums, you get an elimination rate constant of 16%, or 0.16385754424. I would ask you, when you document your elimination rate constants, you document them fully. So never round them up, because colleagues may be using these figures in the future, therefore useful to know precisely what you had. Half-life we document to 1 decimal place, 4.2 hours. And volume of distribution we would approximate to 2 decimal places again. But in this case it was 1.60, so we don't need to specify 1.60, we just document it as 1.6 compared with a population estimate of 1.7. And our recommendation was, if treatment continues, advise a maintenance dose of 19 milligrams every 24 hours. Next dose due at 2300 hours at night, as the concentration will have declined to less than 1. So although they got a dose of 19 milligrams at 5 o'clock in the morning, we don't need to give them the next dose at 5 o'clock, i.e. 24 hours later, because by 11 o'clock at night, using exponential calculations, we can calculate that last concentration will have declined to less than 1. So that, in a nutshell, is it. And to help you, we've got 4 pre-formatted pharmacokinetic consults, and the consults all follow the same basis. My training was consults should be statement of fact, interpretation, and recommendation. So here you've got the statement of fact for two time concentrations. You've got concentrations reported following a stat dose of this. Concentration 1 was this, concentration 2 was this. My interpretation is their elimination rate constant is this, their half-life is this, their volume compared with population volume is this. I can add in any clinical factors that I've taken account of, in that they're got poor renal perfusion, they're hypotensive, they're edematous, things like that, and then make a dose recommendation. Next dose due, and again remember we tend to dose at 11 and 11. Say whether you've prescribed it or whether you've not prescribed it, but the clinician's been asked to prescribe and the nurse has been informed, and then the time it takes. One aspect of these consults that you'll notice, they've all got underscores. And if you insert this document and then just press function F3, so if you've got a laptop, you need to apply the function and then press F3. If you've got like a standard desktop computer, if you just press F3, it will skip from there to there to there to there to there to there. So it will just move between all these underscores, and you just need to fill in the gaps. We've got a gentamicin consult for a concentration after a single dose. It just says, can't do much with a single dose, would recommend you do a further concentration at this time. And we've then got the same for vancomycin pharmacokinetics. If we're using pulsed infusion, then you've got 2-timed concentrations, and you can work out half-life and then make a dose recommendation. And we've also got one developed for vancomycin continuous infusion, and coincidentally we've got a little 23-week 10-day-old baby at the moment that's 540 grams that has been prescribed 20 milligrams per kilogram per day of continuous vancomycin infusion, and his concentration yesterday was 19 with a target of between 15 and 25 milligrams per litre. So we've hit the target with that, and we'll probably find that we use continuous infusions with increasing frequency as we move forward. So that was part 1. Video, training pack, watch, read, repeat. Do it as often as you like. And what you need to do now is to identify some clinical cases, some worked examples, and actually go through the process. It's entirely dependent on you, how often you do it, how many you do, but I would give you a word of advice. You learn through clinical practice. So I can send you details if you like going to prompt me. I can send reminders of these are gentamicin concentrations that have been reported. So if you want to do that, then you really need to pick up some worked examples, some clinical scenarios where you work out and say, right, this is what's happened, this is the dose I'd recommend. So if you've any questions, then speak to any of the children's pharmacy team. It's useful to tag into the junior pharmacist on the clinical rotation, because they will be getting lots of experience of this and can help you with that. But again, there's many people been through this process, and I would ask you to revise, look at this, learn how to use your calculator, and practice. So good luck in all your endeavours.